I'm very disappointed. I'm upset. I was promised I could do the first virtual lecture from a men's room. And obviously that's not to be this time, but hopefully you'll have me back and we'll plan it out for the men's room without video. I don't do, because if I did, you'd mistake it for a comedy act. So we are good doctors. We make our diagnosis of vascular disease, compounding other issues in our diabetic or whoever vascular patient, not necessarily diabetic. We go ahead and we make our referral to vascular surgery or interventional cardiology or interventional radiology. They then send the patient back to us, and the question becomes, what do we do after that? And I want to talk a little bit about this concept of evidence-based medicine. And part of it, you know, when you listen to Dr. Friedman speak, it's good to see him. I haven't seen him in a couple of years. Well, you took me to a restaurant that was the only place my Uncle Jerry would eat. Einstein had said it best. He said that the only form of true knowledge is experience. And if you listen to him speak, a lot of his decisions were made by feel. And I was a resident at one time, and I learned, as we all do, through trial and error, just as he did. He, you know, for example, the skin graft issue, he says, always take a little bit more. Why? Experience. And I tell that to the residents all the time. I say that don't feel badly about things. As you go along, you will develop a sense, a feel. You know, I can't teach a resident the feel of going through a bone and sensing when you're on the opposite cortex. That's something you have to experience and learn, and mistakes will happen along the way. And I try to reassure them. And the same thing applies with wound care. I think there's a sense that you develop that's part of evidence-based medicine, but it's not as though it's a random and controlled trial or anything like that. So being a vascular meeting, again, I want to go back to vascular issues, and these are our options for the dysvascular patient, and you're familiar with them all, and they range again from surgical interventions to percutaneous interventions to debridement back to a viable level to amputating at a viable level. So what happens to these patients after we refer them? I remember being at the Georgetown meeting one year, and Chris Attinger said it best. He said, you know, all of us refer these patients to endovascular people, and they mail us the post-op, post-procedure angios, and they say, look at this nice white line here, and see that, we opened up this blockage and that blockage, and isn't this beautiful? But what Dr. Attinger said is the only thing that matters is, did the wound heal? That's why we sent them to you. So I don't care what the post-angiogram looks like. The question is, did we heal the wound? And if you look at the fate of many of these patients after, for example, drug-eluting stents for lower extremity ischemia, you could see that a good percentage of these patients require, at a minimum, a minor amputation, and still a good percentage end up with a midfoot amputation or below-the-knee amputation or above-knee amputation. So the mere fact that we recognize the presence of ischemia, make an appropriate referral, and get that patient back and follow them and provide good wound care and offloading and so forth doesn't guarantee healing. And unfortunately, that's the reality of it. So the question is, what is success? And success is resolution of the ischemia, but it's also healing of the wound and then proper biomechanical support of that patient and everything else that's involved in trying to prevent recurrence of that ulceration. And you all know sometimes that is difficult. One of the things we need to do is to monitor for restenosis, treat the risk factors that we identify as being causal, and they can be multiple in nature, as you know. And I believe in practical, effective management, and I think we need to start learning to avoid ineffective therapies. We are, when Dr. Friedman says we are the leaders in this area, we're also the biggest suckers. These wound care product people know that they could approach podiatrists, talk you into using these expensive products, whether they have any literature to support them or not. They show you a white paper or so. They say, oh, here's one Dr. Jacobs put this graft on, and look, 9 months later, that wound is healed. And it must have been the product, not anything else that was done, because we seldom use these wound care products in a vacuum. So I think particularly when you're younger, you have to be careful. Charlie Lombardi sent me a list of lectures he'd like me to present at your state meeting this year. And one of them was an old guy lecture, because I'm at the age now, obviously, when I'm doing the old guy lectures. And one of them was, do we old guys deprive patients of new technology? Do we, when they should be getting it? And I was thinking about it, even though your meeting's a while off and I haven't started working on a lecture or not. And I was thinking, the problem is we've seen things come and go. When is the last time anyone in this room who's older did a young Tino suspension for a flat foot? When's the last time anybody in this room did a Celastic Hemi implant for hallux limitus? When's the last time any of you did a drato-bunionectomy? Because we have seen things that seemed like good ideas and applied them, and they just didn't work. And unfortunately, patients get hit along the way, and the reps aren't the ones that get sued. The reps aren't the ones that have to look at that patient who are depending on us to try to save their leg. We're the ones that have to face the failures and patients who don't really want their leg amputated, and you can't blame them if you're on the other side. So you want to try to avoid ineffective therapies as you can. So first of all, we're probably seeing these patients for their wound care much more than the interventional cardiologist is. So I get in the habit of looking for evidence of restenosis. And because we all know when a procedure is first done, their flow is maximum, and over time we lose some of that flow. So the maximum flow is going to be immediately after that procedure. But over time, there's some degree of reocclusion, there's some degree of restenosis, and that nice flow we had initially is not there in the long term. So you get restenosis of these things, you get fracture of some of these stents, and some of them just fail in the short term. So when I see these patients, I monitor for evidence of restenosis, evidence that perhaps there's been a sudden failure, and it is not uncommon, and I think I work with some very good people in St. Louis. It is not uncommon for me to realize that something has gone wrong, and I need to get that patient back to that interventionalist right away. Not only do they appreciate that, forgetting patient care for a second, which is, of course, number one, but it makes you look much better to the interventionalist. And if you want to continue this relationship between podiatry and interventional cardiology, or podiatry and vascular surgery, we need to show some competence in monitoring of these patients. So number one is there an increase in their Rutherford classification? So I mentioned that Rutherford classification is 1, 2, 3, mild, moderate, or severe claudication. 4 is rest pain. 5 is local tissue loss, and 6 is significant tissue loss. So if all of a sudden that patient is now complaining of claudication more than they did previously, or they're having night pain, yes, it could be neuropathy, and sometimes that could be a tough call, because you all know that neuropathy symptoms can be typically or frequently occur worse during the evening hours, just like ischemic pain. And claudication could be pseudo-claudication. A lot of our patients have spinal stenosis and they cramp up when they're walking, but it's coming from their back, it's not coming from their leg. And you can ask a couple easy questions, like when people have spinal stenosis, they typically bend over or they sit down to relieve their symptoms, whereas claudication, you all know, they stop walking at a predictable distance and stand there, recirculate, and then continue walking for a predictable difference. So sometimes there's some overlap, but you want to watch for that. Or if some of these cases seemingly are healing well and suddenly there's a stoppage in progression of healing of their wound, and you can't account for it for any other reason. Their glucose is doing okay. You think, you're going to check certain things like anemia, things like that. You need to get out your Doppler, and hopefully you're all doing Dopplers on a regular basis in your offices, and I certainly do. And watch out for the welfare of that patient and get them back when you think it's appropriate. We've heard several talks today about level of amputation, and we've heard how TMAs are not the end-all, be-all. And while I certainly agree with that, in my opinion, in the long term, because all amputations have failure rates, including below-the-knee amputations. The question is, what seems to be the most durable amputation? And in my mind, it's the transmetatarsal amputation. So we've got lots of data, and Chris Attinger's name's come up several times already in this meeting, and this is another one of his studies, looking at the survivability of patients and their ability to be ambulatory following below the knee versus TMAs. And the TMA patients, as you'd imagine, tend to do better, but there's a reason for that. And I think one of the main reasons is that the patients that we do TMAs on tend to have more distal disease and aren't as sick, because we're dealing with patients, again, that have coronary artery disease, diabetes, dyslipidemia, hypertension, any number of comorbids, congestive heart failure, whatever. And so I think in general, the worst patients we see tend to be the sicker patients, and they don't survive as well. Interestingly enough, the worst survival are patients that require calcanectomy. And if you think about the patients on whom you tend to do calcanectomies, they tend to be sicker patients. Perhaps it starts with a cube or whatever. But the worst survival is actually patients in whom we do calcaneal resections, and the best are transmetatarsal amputations. So I think the TMA is probably the most durable of the things we do. And certainly there's a failure rate with this, as there is for anything that we do. But a TMA permits full weight bearing. We don't use as much energy as you walk. And we heard reference made by other speakers to the fact that once you get into TMA, or not TMAs, but below the knee amputations, there's more work on their heart to ambulate, greater oxygen utilization, and the fact is these patients stress their hearts a lot more. So the TMA certainly is helpful, and they are durable. Do they have problems? Of course they do, but in general, I think it's helpful. Dr. Friedman mentioned transferring tendons. If infection is not an issue, then I will do that. And I'm surprised that most people in St. Louis actually don't do some kind of tendon balancing. It surprises me because really, pound for pound, I would put St. Louis up against any city in the United States. We have a wonderful population of podiatrists in my city. All of them, or most of them, are very well trained. They're very good surgically, and yet they'll do a TMA and not consider either a split anterior tibial tendon transfer that I do, or perhaps a lengthening of the anterior tibial tendon that was mentioned to you earlier. But you also have what are called osteomyoplastic and myodesing operations. So osteomyoplastic is if the situation allows it, meaning necrosis, level of ischemia, infection, if it allows it, I will sew the extensors and flexors over the stumps of the metatarsals to each other, or that's called an osteomyoplastic revision of an amputation, or osteomyoplastic, where you can actually sew the tendons down to the periosteum, or use some technique that you've seen otherwise. But they're certainly not without failure. But these are cases when I was younger and first starting, and we had this philosophy that you save the foot at any expense. I don't expect things like this to survive. I mean, you know, you have 3 remaining metatarsals. They all have neuropathic changes to them. As you all know, at times, once they ulcerate, it can be very difficult to discriminate neuropathic bone change from osteomyelitis. The pathology is generally going to be the same. And that's been shown ever since Andy Meyer's great study, blinding pathologists and asking them to look at samples of bone and saying, yes or no, is this pathology neuropathic, or is it osteomyelitis? And the pathologists at Temple could only agree in about 30% of the cases, or 40% of the cases. So over half the time, even the pathologist can't decide whether that bone sample is osteo or neuropathic. So rather than get into that, I tend to go to that TMA. And again, you know, I will give them 1 ray. If it's under the 5th met, I tend to resect the 5th metatarsal head. I think if there's 1 ray that patients seem to tolerate without a high incidence of transfer ulceration, at least in my experience, it's been the 5th met. But once they get to a 2nd ray, I tell them I think the TMA is the way to go, because we're just going to keep bringing you back and bringing you back and bringing you back, and this is far and away the most durable. You also have to worry when you do isolated rays of problems. One is obviously transfer of the ulceration, and obviously here's a patient of mine that we did a first ray amp, and the patient now has a sub-2 ulcer, and it's certainly no surprise to anyone in this room. To your right, you see a patient that rapidly developed digital contractures. The patient has motor neuropathy. And as a result of amputating the first ray, there's been rapid contractures of the toes. And I've seen that every now and again on TALs where I think I probably over-lengthened the TAL, or the patient had weakness that was more than I would have wanted because of their coexisting motor neuropathy. And they rapidly developing these toes, and then they start developing ulcers on the tips of the toes, and you know all the rest of the story. So everything we do has potential consequences because we're removing part of the weight-bearing portion of the foot. That is one of the arguments that was raised in one of the classic studies done looking at treating osteomyelitis of the forefoot with antibiotics and not removing the bone. Because classically in the United States, the teaching is, oh, there's bone infected, it must come out. And yet you've got studies that show that's not true in the forefoot. And the difference and because once we start removing part of that weight-bearing surface, you know the patient weighs the same, and that weight has to go somewhere. And again, they have skin changes from autonomic neuropathy. They can't tolerate that weight transfer. They develop deformities because of the motor neuropathy. So if we can preserve reasonably their weight-bearing surface, we try to do that. So treating forefoot osteomyelitis, meaning metatarsal heads and toes with antibiotics alone without removing bone, has about a 73% success rate. You have a higher success rate, about 10% more, if you remove the bone. The difference is if you treat with antibiotics alone, the reulceration rate is much lower. And it's much lower because you preserve the anatomy. So that these considerations are difficult from patient to patient after that. Can I get this reset because the changer's not working? Can I get you to work on that a little bit? Thank you. And we all have these situations. So here's a patient that has had the first and second rays partially removed. And look at the contractures of the toes on the right foot compared to the left foot. That's not a coincidence. That's due to the motor neuropathy and the effects of losing the first and second ray. So digital amputations I look at as being temporizing. One of the worst, of course, is the first ray, and we're all taught that the first ray takes 50% of the forefoot weight bearing, and you got to think about this during late mid-stance and propulsive phase of gait. So here's a nice study that was in Journal of the American Podiatric Medical Association looking at 48 first ray amputations. Half of those required revision, and half of those had to be converted to a TMA. And again, this is not surprising. And certainly not to anyone in this room. It might be surprising to a physician who's not as knowledgeable about weight-bearing function of the foot. But the fact is, when I amputate a first ray, I tell the patients, you're at 50% risk for transfer ulceration and the need for some additional surgery. And I look at it as temporizing. And just like you or anybody else, I do my due diligence. I try to put things in their shoes. I try shoe therapy. I work with ped orthics. It's not like I don't try, but I know in the long term that these patients are likely to require a revision. This was a survey by Tom Rukas, again, looking at the fate of patients after first ray amputations, and you can see the numbers as well as I can. About a third go on to transmetatarsal amputation, and about 30% go on to a below-the-knee amputation. So many of these things are temporizing at best. And, you know, are they perfect? Of course not. Patients develop varus rotations. They develop plantar flexion rotations. And, you know, Dr. Friedman had his approach. Dr. Steinberg has his approach. I have my approach. And I try to tell patients that all the time. The standard of care is not one answer. In medicine, there are frequently many correct answers. And we function in a range like this, not like this. My old professor, Dr. Ganley, used to say, the only place they practice perfect medicine is in plaintiff lawyers' offices. And sometimes I joke with the residents, but I kind of mean it. A lot of times I say, if we have a difficult decision to make in the OR, I say, let's call Brown and Crouppen. They're our big, you know, we'll sue anybody for anything. Get them on the phone and find out what we should do. Because I can't make a perfect decision, and patients need to understand that going in. The one on the right was a patient of mine that had a TMA, and these are all neuropathic bone changes. I went ahead and scanned them. This is an older case, but I did at that time technetium and then a gallium scan, if those of you remember that, and it all came back negative for infection. But these things do happen. So are they perfect? Of course not. If you look at work published by Dane Wukish out of the University of Pittsburgh when he was there, Bob Freiberg was one of the co-authors, and they looked at risk factors for complications in foot and ankle surgery. And you would think, oh, that's easy, it's vascular disease. But it wasn't. The number one risk factor is neuropathy. So they looked at 4 types of patients: patients with diabetes and neuropathy, patients that had diabetes without neuropathy, patients that had no diabetes but had neuropathy, and then patients with no neuropathy, no diabetes. And the number one risk factor is, of course, diabetes with neuropathy, but number 2 was patients that had neuropathy of any etiology, alcohol, B12 deficiency, whatever. So neuropathy is a major player, more so. And then I think about this. I mean, I look at this foot, and I say, you know, is this going to last? And of course it's not. Of course it's not likely to. Every now and then we get a patient with a funky looking foot and they've had it for 12 years and they do just fine. But we spend a lot of money. We do a lot of surgery. We take these patients out of work. We take them away from family. We put them in institutions. We do this, that, and the other thing. And in the end, they end up with an amputation anyway. And if they don't end up with an amputation initially, the question is, did we leave them with a functional amputation? So I think this is the challenge in treating these patients. And it's always a damned if you do, damned if you don't. And if you know the end of the story, it's like Columbo, where, you know, the thing that made Columbo series famous, if you don't know, those of you that are younger, it was the first detective show where they showed you up front who did it. Every other detective show, you had to wait till the last scene, like Perry Mason or whatever, and they finally told you who the bad person was. And Columbo, they tell you up front. So it's real easy in hindsight to say, well, you know, I probably would have done this and I probably would have done that, because you know there was a failure. One thing, I know that here in New York, there's some issues. I treat a lot of venous ulcerations, and I want to tell you, I think podiatry is missing the boat in doing good. I think we should be much more involved in treating venous disease. But I want to call your attention to something. Number one, there's increased emphasis on venous interventions now. You've had whole sections at this meeting just on venous disease. But I just want to remind you of something. I was raised, like most of you, you go through podiatry school and they say, okay, venous ulcers are this, arterial ulcers are that, neuropathic ulcers are this, and then you have these outliers like hemoglobinopathies like sickle cell and connective tissue diseases, and here's the characteristics of each. But about a third of the patients you see with venous ulcers have corresponding arterial disease. And the converse is also true. So don't just classify patients as having just venous disease or just arterial disease, because if they're not getting better, and one of the reasons for so great difficulty treating venous ulcers is that some of them have an arterial component and we get misled. We have this big fat leg in front of us and they've got obvious lymphedema and venous insufficiency, and they've got a medial malleolar ulcer. You go, oh, this is definitely a venous ulcer. We'll compress. Don't forget there's an arterial component, and you want to identify that. Send them for arterial studies too, because if they have corresponding arterial disease, when you compress them for their venous disease, you may exceed their intra-arterial pressure and end up with necrosis from properly applied pressure. But unfortunately, they couldn't tolerate the pressure because of their corresponding arterial disease. So lastly, I want to say a few words about wound care products. I have a passion about this, and this was the first wound care products that were available during caveman times. So this is when I was in podiatry school. It's one of my professors there instructing me. Steinberg, it's not that funny. So all of us, again, know the basics, but I think we need to start looking at reducing the cost of wound care, because these companies are throwing every kind of product at us, and podiatrists are rapid adapters. And I think we pick up all these things, and I think we're different from physicians in that regard. And I hate to say it, but it's true. I think we are easy marks. I think the key is ulceration prevention and getting compliance. It's amazing how many of these patients are not compliant. I think a lot of times there's no advantage to referring patients to wound care centers. Now, I don't mean a place like Georgetown, But in St. Louis, for example, there's not one wound care center where any of the doctors have any wound care credentials, and they're primarily primary care doctors who were ne'er-do-wells in private practice, and they're picking up a few extra bucks hanging out in the wound care center. They don't know how to debride. They're not familiar with all. I had one doctor, the nurses came to me and said, could you talk to Dr. So-and-so? He's treating these plantar wounds and the patients are just walking all over him. So I went up to him and I said, Dr. So-and-so, the nurses were just, mentioning about, a lot of times in podiatry, when we have these wounds on the bottom of the foot, a lot of times we kind of try to keep them off it. And he looks at me and goes, are you talking about offloading? I said, yeah, that's right. That's what I'm talking about. He goes, I don't believe in that. And I said, so you're an offload agnostic? And he was. And so, but that goes on in a lot of wound care centers. And I think it's unfortunate that there's de facto referrals of patients to wound care centers, and they're not all like Georgetown. They don't all have Steinbergs and Attingers and Armstrongs and people like that in them. They're not. So, that's, I think you need to cut back on unproven therapies. People coming in and saying, well, this fish off the coast of Iceland has got a skin that provides healing. And you go, do you have any data? Can I see some studies that show that? And it sounds funny until you realize the cost. I just got a communication from a wound care company, I won't say who, a podiatrist here in the United States, that last year was paid by Medicare $25 million for wound care products for treating ulcers. $25 million. Now, you can't tell me this is possibly legitimate. If I got $25 million from Medicare, you could ask me to lecture whatever meeting you want. You won't find me. You will not find me. I will be in some island in the Caribbean. Maybe I'll sell those T-shirts that last till the first time you wash them, but that's going to be it. And I think, you had mentioned something that made me laugh. We put wound care products on these things like an expensive, say, amniotic graft. And what do? The next week, the patient's in your office, you're debriding it off. And it's kind of like, well, you got to give the wound a chance to heal and to work. And I think sometimes patients don't require debridement every single week. So this is kind of the problem, and that's why we're so overregulated now, because we're using all these products and sometimes they're just not appropriate. I know Dr. Friedman tried to give you some guidelines on his approach to it. Jeff Robbins published this some years ago, and he looked at the weight of the literature to support common products we use for treating diabetic ulcers. And you could see that in general, the weight of the literature is quite low. I want to close with this. I might go 1 minute or so over. I apologize. But the International Working Group on the Diabetic Foot, of which I think Dr. Attinger is one member, if you don't know, this group looks at the literature published on wound care products, and they do it in an objective manner. It's sort of a who's who of people in the world who are considered authoritative in wound care. So I want to just share this with you. Number one, debridement. Sharp debridement is their recommendation as opposed to other methods, and you can see their recommendation is strong. Number two, choice of dressings. It should be based on some rationale, including comfort, cost, and ability to absorb the exudate. Number three is special dressings. Again, we get pitched to use expensive antibiotic-impregnated dressings and all this kind of thing. They're only good if you're trying to decontaminate a wound. But using topical antibiotic therapies just because you think it's going to accelerate wound healing is not going to work. I'm going to skip over that one. Systemic hyperbaric oxygen. It is considered appropriate as adjunctive therapy only, and for ischemic wounds, not for diabetic ulcers that are strictly neuropathic. Hyperbaric is not considered appropriate for those patients. And if you look at the largest papers published on use of hyperbaric oxygen in reputable journals like Diabetes Care, the largest studies show there's simply no reduction in amputation rate. There is simply no increase in ulcer healing rate with systemic hyperbaric oxygen. Now, that's the reality of this. So the International Working Group says if you're going to use hyperbaric oxygen systemic, it should be used for ischemic wounds, and it should be used adjunctively together with other therapies. They suggest not using topical oxygen. We don't have the data to support its use. But here again, we have corporate-driven advertisements and lectures being given at our meetings advocating this without any scientific basis. What about wound vac therapy? Well, you saw from Dr. Friedman some good examples of that. Wound vac is indicated for post-surgical ulcer management, not as primary ulcer management. So if you notice, every case that Dr. Friedman showed you was post-surgical. He didn't just say, oh, here's a neuropathic ulcer, we're going to go right to wound vac therapy. So they're post-surgical debridement. And it's not really suggested for non-surgical foot wounds or ulcers, okay? Placental-based products, again, you saw a good rationale from Dr. Friedman. It's a reasonable approach to how and when to use these things, but you use them, again, adjunctively and not as a primary care treatment, and use them selectively. They suggest not using growth factors, autologous platelet gels, ozone, topical CO2, nitric oxide, that type of thing. Let me go back for just a couple more slides. They do recommend that you consider the use of autologous combined leukocyte, platelet, and fibrin factors. They suggest that you not use some of these miracle cures that are being advocated, like electricity and magnetism and ultrasound and shock waves. And as far as nutritional cares, they feel that if your aim is to improve healing, they just don't feel that the data is there to support nutritional therapy. Now, personally, I do nutritional therapy, and you heard a wonderful presentation earlier about that. But I'm just conveying to you the data as reviewed by the International Working Group on the Diabetic Foot. So in summary, after the intervention, monitor the patient for post-procedure complications. Consider doing durable amputations. You may do a temporizing amputation to control infection, but in the long term, consider more durable procedures. And in my mind, the most predictable long term is still the transmetatarsal amputation. Consider effective wound care therapies and comprehensive preventive care. Lastly, I'm going to do a commercial here. We do have a seminar every year. This is our 35th year, the St. Louis Podiatry Seminar this year. It's on these dates down at the Swan Hotel in Disney. It's also virtual and on demand, so I invite you to attend or listen online. And it's a seminar that's aimed at the average practitioner. It's not for the super surgeons. If you're a super surgeon, you go to ACFAS or AOFAS. It's not for Charcot reconstructions and flat foot surgery. It's aimed, and it always has been, for everyday practice, for the everyday practitioner who deals with these problems that we are all dealing with day to day. This is my last presentation, but I do thank you for the invitation to come up. I always like sharing thoughts with my colleagues, and I've really enjoyed many of the presentations. I really enjoyed yours on nutritional therapy. I learned a lot from that, and it's always nice seeing Dr. Friedman. I haven't seen him in a couple of years since COVID hit. So it's nice seeing you and Dr. Treppel and everybody, Ron Suave, who I'm embarrassed to say was a resident of mine. And I take no responsibility for him. Thank you.